Hello, welcome to our second open lecture series of the summer semester. And it is with great pleasure and admiration that I introduce my mentor and my coworker, Matthew. He is a psych nurse practitioner who I've had the pleasure of orientating with him 12 years ago. When I was a brand new graduate, he took me under his wing and he taught me, still teaches me quite a bit of stuff. He graduated from University of Missouri, or Mizzou, and has been in the psychiatric field in one way or another since 1981. He has been involved in numerous research studies with Psych Care Consultants here in St. Louis, Missouri. And he's done quite a bit of research on long-acting injections as well. And so without further ado, I would like to introduce you to Matthew Lindquist.
Thanks, Brandy. I know my screen says Sherry Lindquist. That's because my wife is a professor and I'm using her Zoom account. So I'm not Sherry, I am Matt or Matthew. Just to add a little bit to the history that Brandy gave quickly, I like to tell this a little bit because I think it's an interesting story. My first job working in this field was at Northwestern Memorial Hospital in Chicago. And this was way back in 1981. And while I was there, we had a Grand Rounds event where one of Anna Freud's students came and spoke to us and taught us, and we got to talk with her too. Now, if you're not familiar, Anna Freud is Sigmund Freud's daughter. So basically that means I'm 3 degrees of separation from Sigmund Freud. What that also tells you is how young a field psychiatry really is. The fact that I'm just that close to having contact with Sigmund Freud directly. But I worked for years as a mental health worker, and then became a nurse and an addictions counselor in 1986, and became finally a nurse practitioner in 2004. And not only did I do research with psych care research, but I also did research with Mid-America Research. And when I was working up in Chicago, we did a research project too for one of the men that I worked with, who was also working on his master's in psychology, and participated in that research project as well. So I've done a bit of research. A lot of the studies that I've done in the last, decade or two have always been with long-acting injectables. So I thought it would be good to talk about long-acting injectables. Of course, we call them LAIs in brief because that's the very simple, long-acting injectable. In nursing and psychiatry, we like to use 3-letter acronyms. So LAI for the long-acting injectable. They're used in psychiatry to treat a variety of mental health conditions, but the biggest market for these agents is to treat schizophrenia. But they can also be used in treating schizoaffective disorder and bipolar disorder. And though right now there's only a couple agents actually available to treat bipolar disorder. Psychiatry has been looking for ways to better help patients stay out in the community and participate in the environment ever since the advent of modern psychiatry, partially at least because we went through the process of deinstitutionalization. Deinstitutionalization occurred in the 20th century, first by releasing patients from these large institutions that they were being kept at. We reduced lengths of stay for the admissions and readmissions, and then we also changed psychiatric care so that we were working on discouraging patients from feeling dependent on the system and the hopelessness that occurred with this dependency. This meant that we needed to find ways to help patients with mental illness be able to stay within the community. And as the availability of beds for psychiatric inpatient care diminished, such that for every 100,000 US citizens in 1955, there were 340 psychiatric beds. By 2005, there were only 17 per 100,000 citizens. So we had to find ways to meet the goals of helping individuals stay in the community. There had to be more ways to help patients succeed when they had these major mental illnesses and be more independent. And for this purpose, probably more than any other, I think, was why the LAIs were developed. Schizophrenia has been shown to have a genetic component. Roughly 1% of the population suffers from schizophrenia, and it's generally divided equally between males and females. Vulnerability to schizophrenia shows genetic concordance in monozygotic twins at nearly 50%, dizygotic twins at 17%, and 6 to 17% between first-degree relatives, parents, siblings, or children. Still 2 to 6% between incidents between second-degree relatives, the nieces and nephews, and third-degree relatives, it's still approximately 2%, so it would be first cousins. Schizophrenia has an economic burden on society estimated at $155.7 billion in 2013, and that includes direct healthcare costs of $37.7 billion. Bipolar disorder has an estimated lifetime estimate of roughly 1.3% of the population. Again, basically equal between males and females. Cost estimates for the societal burden for bipolar disorder vary from 24 billion to 42 billion annually. That's 1991 values, so you can tell it's a little bit out of date, based on whether you're looking at incidence or prevalence studies, though. Hospitalizations still account for a large amount of this cost, though morbidity, mortality factor in as well. Then there are more intangible burdens on the family and health-related quality of life. In studies of bipolar looking at genetic transmission, we find that children with one parent with bipolar disorder have about a 10 to 25% chance of developing the disorder. But when both parents have the disorder, that number goes up from 10 to 50% chance. Furthermore, twin studies have shown the rate among identical twins rates from 40 to 70%. And in most cases, individuals with bipolar disorder will have at least one close relative with depression or bipolar disorder. With these two major mental illnesses creating such a burden on society and on the individual, it's become necessary to find a way to increase quality of life for those individuals and decrease the burden on society. Again, I propose that utilizing long-acting injectables may, in at least a small way, have an impact on both of these aspects of the illness. So I'm given here just a review of the long-acting injectables and some of the issues that we need to be aware of in treating individuals with these two illnesses. Long-acting injectables were launched in 1966. Oh, I've got my slides mixed up here somehow or another. Don't know where I want to be. These things happen. Oh, well, anyhow. With the first agent being prolixin enanthanate, there we go, or flufenazine enanthanate. Unfortunately, the product had a significant number of unwanted side effects, including the typical side effects what one might expect from flufenazine, but also distressing muscle spasms that usually occurred within 24 hours of the injection and required immediate administration of an anticholinergic agent. So 18 months later, prolixin decanoate came to market. It took a couple of decades before another long-acting injectable became available. And in fact, it wasn't until 1981 that haloperidol decanoate was first released in Europe. And the US, it was released in 1986. To add to that, that's the year I graduated from nursing school. These two decanoates were both medications that were sesame oil-based medications. They were thick and difficult to inject quickly. You often had to warm it up a little bit in your hand first so that it was thin enough that you could even inject it, because when it's cold, it's very thick. And the medical community also was concerned about lack of efficacy, fears of increased side effects, as was seen clearly with the flufenazine enanthanate, and then the concern that it was an attempt by psychiatrists to impose treatment upon patients without due regard to their feelings or rights. Subsequent research did suggest benefit, so these were adapted into practice. However, in this country, they were very slow to be adopted, and usually saved for the patients that had relapsed multiple times, often because of non-compliance with medications was an issue. But this is a significant issue too, because we know that the more time someone relapses, the more brain damage occurs in schizophrenia. So, we got to make sure there's ways of keeping people stable sooner than having relapsed over and over and over again. Medical legal concerns were also an issue, and forensic patients sometimes would get court-ordered long-acting injectable treatment to attempt to make sure the patient stayed on their medications. This had implications for other patients accepting treatment as well. Hospital stays were relatively long up until the 90s, and along with the use of seclusion and restraints, because patients that lost control of their behavior for one reason or another often would get medication injected to calm them. And patients developed a sense of that getting the injection was punishment for their behavior as opposed to a means to help them regain control of themselves. And frequently this kind of threat was used on patients, like if you don't stop it, you're going to get a shot. And I've heard that even within probably the last year. In a side note, I worked on a children's and adolescent unit, and as they were less capable of controlling their aggressive impulses by virtue of their lack of development of internal controls, it became a popular expression where one child would say to another, "You're going to get a booty dart," or "They gave me a booty dart," to indicate they got an injection in their hip of a medication to help them calm down and, or act as a medical restraint. Introduction of second generation antipsychotics or atypical antipsychotics, so-called when clozapine, clozapine was created because someone commented that since it had a greater affinity to serotonin receptors than to dopamine receptors, it was atypical as an antipsychotic, and the name stuck. So we now call all those second generation antipsychotics atypicals. So it was also thought that atypicals would be better at helping with both positive and negative symptoms of schizophrenia instead of just the negative symptoms as the first generation had, though this has pretty much been debunked. They really are no better at treating negative symptoms. Some say maybe even a little bit worse, and there's still debate as to whether or not they're that much better at treating the positive symptoms. So in 1990, when Clozaril was first introduced in the US, earlier in many European countries, it was only allowed for treatment-resistant psychosis due to significant risk for agranulocytosis. So these clozapine clinics came about. Clozapine was actually built off the imipramine molecule, which is a tricyclic antidepressant, had the common name tofranil, and it showed great benefit in treating psychosis that was resistive to response to all the older antipsychotics. It was the first new antipsychotic to come out in over a decade, but it was expensive, partially because they expected it to have such a small market since it was only for treating the treatment-resistant psychosis. It was expected also then that the patient, the provider, the pharmacy, wherever it was being given, also all had to be part of what's called a REMS program, so that the patients could be monitored to make sure that everyone was aware if there was any change in their neutrophils and lymphocytes and such. Many other new atypical antipsychotics followed: olanzapine, risperidone, quetiapine, ziprasidone, aripiprazole, and more since. Claims of fewer extrapyramidal symptoms, equal effectiveness to the older antipsychotics on negative symptoms and impacting positive symptoms of schizophrenia. They were better tolerated, yet adherence was not really any better. And then we became aware of metabolic syndrome, which is, of course, the link between the atypical antipsychotics and the oncoming events of diabetes caused by the medications. This then gave us something new to watch out for. Still, they did seem to be better tolerated, and it was anticipated that they may also give a better quality of life than the typical antipsychotics, and their adaptation proceeded. Further analysis demonstrated these newer agents slowed frontotemporal cortical gray matter decline and gave a greater degree of neuroprotection than the first generation antipsychotics. And that's probably a good enough reason to use these more so than the first generation. In spite of these improvements, though, since better adherence to taking medications didn't come about, relapses continued. Patients continued to struggle with declining symptom control and declining brain function. Now, welcome to the 21st century. As such, second generation antipsychotics started coming out in long-acting injectables. The first was Risperdal Consta in 2003. Based on risperidone, which was in turn built off the haloperidol molecule, it came out with dosing strengths of 25, 37.5, or 50 milligram doses. It's very good for treating schizophrenia, and later it added a maintenance indication for bipolar I disorder. The problem is it has a lag time before it's fully in the system, and so clients have to stay on Risperdal for up to 3 weeks after getting their first shot to make sure there's adequate levels in their system. And remember, they get shots every 2 weeks, so that means that they get 2 injections and then another week of oral medications before they can start coming off of it. And risperidone still has issues with extrapyramidal symptoms and especially elevated prolactin levels. And risperidone is known as having the largest increase in prolactin levels of any of the molecules, so that we get people with gynecomastia and things of that sort. The next atypical to come out after Risperdal Consta was Zyprexa Relprev in 2008. It's perhaps the most difficult of the long-acting injectables to give. You must be registered again in the Zyprexa REMS program, as must your institution. It can only be given at sites that have access to emergency medical treatment, because occasionally there is a symptom which occur, which is called post-injection delirium sedation syndrome. So patients have to be monitored for 3 hours after the injection. But like oral Zyprexa, it's a potent antipsychotic and not just to be put aside easily. Dosing is complex, though, converting 10 milligrams of Zyprexa to 210 milligrams every 2 weeks or 405 milligrams every 4 weeks. And you do that for 8-week period of time, and then you drop the dose down to 150 milligrams IM every 2 weeks or 300 milligrams every 4 weeks. So you can see, even just my telling you this, it shows how difficult it is. That's just for 10 milligrams. If it's 15 milligrams of oral Zyprexa your patient is being treated with, then you start at 300 milligrams every 2 weeks, then 210 milligrams for 2 weeks, or 405 milligrams every 4 weeks. Then after you've been on it for the 8 weeks, then you drop it down to 300 milligrams every 4 weeks. So I can keep going and do additional doses, but it's just to demonstrate that it's particularly difficult to use. And in non-smoking females, 65 or older, debilitated or at risk of hypotension or slow metabolizers, then the starting dose is 150 milligrams for every 4 weeks. So you have to be real careful with it. The next medication to come onto the market was in 2009 Invega Sustenna. Invega improved upon Risperdal in 2 ways. One, it was a monthly injection, and 2, from the first injection, you could stop oral antipsychotics. It does require a booster injection to get it going. So you start patients on 234 milligrams and a week later give them 156 milligrams with an anticipated dose of 117 milligrams, which is roughly equivalent to 6 milligrams of oral Invega. Now, obviously, if patients are on higher doses, then you might be going to the 156 or the 234 milligram doses, but it also comes in 78 milligram and 39 milligram doses. Invega, though, is paliperidone, which is the active metabolite of risperidone. As such, it's a little bit less potent than risperidone, and it still has a strong impact on prolactin levels. It's also only indicated for schizophrenia and schizoaffective disorder. They never went after that indication for bipolar disorder. That sometimes becomes a problem with dealing with insurance companies and such. In 2013, then, Abilify Maintena came out as the next LAI with a recommendation for 400 milligrams for everyone, although it's also available at 300 milligrams. Both of those come now in pre-filled dual chamber syringes versus having to reconstitute the powder from a vial and then pull it up in a syringe. But it also has a lag time, so patients need to be on oral aripiprazole for 2 weeks after the first injection. Dosing adjustments due to metabolism of the medication in individuals that are either slow metabolizers or of 2D6, CYP2D6, or because of concurrent medications, make it so it can also be dosed at 200 milligrams or 160 milligrams, but in those cases, you do have to reconstitute from the vial. Initially, it was indicated only for schizophrenia maintenance, but later on, they added that after demonstrating its usefulness, that it can be used in the acutely relapsed patient with schizophrenia. And Otsuka, the company that makes aripiprazole or Abilify Maintena, did a head-to-head comparison study on quality of life against paliperidone palmitate. So Abilify Maintena versus Invega Sustenna. This is the only head-to-head study that's ever been done with the LAIs that I'm aware of. And it did demonstrate superior quality of life with Abilify Maintena over the Invega Sustenna. Then in 2017, the indication for bipolar maintenance was obtained from the FDA, demonstrating superiority over placebo on the length of time to recurrence of symptoms, particularly of mania or mixed mania episodes. Though depressive episodes, it was not significantly different than placebo. So it really shows that Abilify in the bipolar patient is helpful in mania and mixed states, but not really that helpful in depression. Next was Aristata in 2015, which is also an aripiprazole product like Abilify Maintena, but it's a prodrug formula, aripiprazole Loroxil. It comes in a range of dosing options from 441 milligrams up to 882 milligrams, with the 662 milligrams in between. And then later on, they added 1,064 milligrams, but 1,064 milligrams is not a higher dose. It's just a longer acting dose. So 882 milligrams can be given every 6 weeks, and then it's equivalent to the 662 milligrams. The 1064 milligram can be given every 8 weeks or every 2 months, and it's equivalent then of the dosing strength of the 662 milligrams. So that's where it gets confusing. 882 milligrams every 4 weeks is still the highest dose. Then 662, 882, and 1064 all are equivalent doses, but at different periods of time being given. And then 441 is the lowest dose. After that, the next medication to come out in the long-acting world was Invega Trinza in 2015. It's a 3-month-long injection of Invega or paliperidone. Patients, though, have to first be stabilized on Invega Sustenna for 4 maintenance injections. So that means you don't count the initiation dosings, the first 2 shots, but 4 after that, then the person can be started on Invega Trinza. This makes sure they're already in steady state and that they're doing well before you put them on a medication that's going to go for 3 months with a single injection. Invega Trinza can be dosed at 273 milligrams, 410 milligrams, 546 milligrams, and 819 milligrams. And they correspond with the same doses of Invega Sustenna. So the 819 would be the 254, 546 milligrams would be the 156, et cetera, et cetera. The next injection that became available is not actually a true long-acting injectable. It's Aristata Initio. But Aristata Initio is not intended for solo use. Aristata Initio is a way of being able to start Aristata without having to have someone stay on oral aripiprazole for 3 weeks, which is what you have to do with Aristata. So instead, you give them a single pill of Abilify. You give them the Aristata Initio, 675 milligrams, and you give them whatever dose of Aristata that you intend to keep them stable on. And those can all be done on the same day. And this initiation process then allows for no more oral medication needing to be taken after that. This way, you can be sure that the patient is actually established at the therapeutic level that you're aiming for, that you would otherwise be unsure about because you can't be sure that patients will take the oral medications. And this is one of the reasons why the long-actings came about to begin with, to help people stay on long-acting or stay on their medication in order to get the better control. Now in 2018, Perseris was added to the array of medications as long-acting injectables, but Perseris is really different from the others in a couple ways. First off, it is risperidone. So again, we're going back to the original LAI of the 2nd generation. So it's risperidone, but it's a month-long injection instead of 2 weeks long. And 2, it's a subcutaneous injection rather than intramuscular. It's available in circulation within 4 hours, so there isn't need to supplement with additional medications. And in this case, the medication is suspended in basically liquid suture material that dissolves slowly over time after it's injected. And it keeps a steady dose in the person for the month period that's expected. It's usually given in the abdomen. You kind of go in a clockwise succession around the navel in order to inject it. And you can still feel where the injection was given, sometimes even 2 injections later, but the medication has been dissolved and has been absorbed over the course of that month. It was approved by the FDA in 2018, but really didn't become available in 2019. So that's kind of a summary of all of the medications that are available in long-acting injectable form. Now you might wonder, why is this important? Well, In comparing randomized controlled trial outcomes of LAIs versus oral antipsychotics in treating schizophrenia, it looks like there's no difference in the effectiveness of the drugs, according to a meta-analysis done all the way back in 2013 and reported in the Journal of Clinical Psychiatry. But they suspected that patients in a research study may be better at medication adherence than in the general population. So they went on to look at something called mirror studies. Mirror studies, a patient will spend 6 months on an oral antipsychotic and 6 months on a long-acting injectable. Sometimes they'll be on the long-acting first, sometimes they'll be on the oral first. Co-primary outcomes were hospitalization risk and number of hospitalizations. Secondary outcomes included hospitalization days and lengths of stay. The data synthesis showed that LAIs showed strong superiority over oral antipsychotics in preventing hospitalization. 16 studies with a population of 4,066 individuals in the study showed a risk ratio of 0.43 with 95% confidence interval, or between 0.35 and 0.53, with a p-value of 0.001, and in a decreasing number of hospitalizations, 15 studies, 6,342 person years, rate ratio of 0.38, again a 95% confidence interval, and a p-value of less than 0.001. This strong advantage was also observed for secondary outcomes and in multiple clinically relevant subpopulations and treatment groups. Given the possible biases in mirror study images, though, such as expectation bias, natural illness course, and time effect, cautious interpretation is required. Nevertheless, the population in mirror image studies better reflects the population receiving LAIs in clinical practice. Now, recently, also a new study has come out for Abilify Maintena, where they're looking at treatment as usual versus Abilify Maintena, showing again some superiority of being on the long-acting injectable Abilify Maintena. Again, that one's though just one study so far, and so more needs to be done. That kind of wraps up what I wanted to cover today. Just again, brief information about the medications, and that covers it. So if there are questions, I can take those. If not, then that's it. I think a lot of the microphones are muted, Brandy, so I don't know if you might have to unmute them, or because I see yours is mute.
Yes, if you have a question, you can type it in the chat box or you can speak in your microphone. But yes, everybody is on mute. So if you want to ask a question or a comment, please unmute yourself. And this was a good, I still learn a lot. This was a good presentation.
Thanks.
Quick question really fast. Do you mind just going back to the slide with all the injections so I can take a screenshot of it?
Oh, no, I don't have a problem with that at all. Hold on a sec.
And Mr. Lindquist works inpatient at one of the hospitals here in St. Louis, and is
St. Charles.
St. Charles, Missouri, right north of St. Louis. So would you say that the culture of, I know when I went through school, I graduated in 2012, that many people believe that patients were still very hesitant with injections. What I have found in my outpatient, and I work when the patients are mostly stable, where he works in crisis. And so, but I find that patients are very receptive to it. Getting injections, some of them ask for it, which I just love because it makes it easier when they ask for it. But in your practice, where they are in a crisis, that's why they're admitted most of the time, what is your perception on how students perceive starting a long-acting injection?
I'm not sure how the students perceive it per se, but I can tell you that, and I don't, again, sometimes the patients will say they've heard about it and they'll ask about it and want to get started on it. But we even find patients that have been on antipsychotics for a long time and have schizophrenia that no one has ever asked them before about going on a long-acting injectable, and that they love the idea because they would prefer to not take medications by mouth if they can help it. And so we find that many patients are really very good at going along with and accepting taking the injections nowadays. Now, you do get some that are resistant because of needle fear. Seems like that's particularly true of patients that have tattoos and such. I don't know what's the difference between an injection from this and I think getting stuck so many times to get a tattoo is probably worse, but they still are a little bit resistant to getting the injection. I asked some of them which hurts more, going into the hospital and staying there for a month or for a week or whatever long it takes them to be, or getting an injection once a month so you can stay out of the hospital. And that's sometimes enough to help people make the decision to get the injection.
Great. Yeah, I would say I agree with that in my limited focus. Again, we work in different areas of mental health, but I would say the same. And then my next question, I don't want to hog it from the students who may also have questions, but my next question is, they were trying to push, and they may have already gotten it approved, for Abilify Maintainer to be used in patients that have bipolar disorder. Do you commonly see patients that have bipolar disorder on long-acting injections?
You know, again, when they're coming into the hospital, they're usually in crisis, so most of them are not. But those that are coming in with manic or mixed episodes, then yeah, I do often try and get them onto Abilify Maintainer because if I can keep their bipolar disorder more stable, that's really important. The problem is, of course, that a lot of them do come into the hospital in depressed states as opposed to mixed states or manic states. And bipolar disorder is still an illness more of depression than of anything else. So we have to make sure that we are treating depression and that we're prepared to treat mania and mixed states as well, because we get all of those conditions coming in. So sometimes people will actually end up on more than one atypical medication. And it's nice that you can do something like Abilify Maintainer to keep the mania and mixed states away, and then maybe something else like lorazepam or quetiapine or something like that to keep the depression under control. And so we have lots of different options.
And does anybody else have any questions for Matthew, Mr. Lindquist?
And you can just call me Matthew or Matt. You can even call me Sherry according to my tag.
Yeah, one other question for you.
Sure.
Financially speaking, for the patients, do you know if it's more expensive to be on these LAIs or just as opposed to oral antipsychotics?
As almost all of the orals of these medications are now available generic. In fact, I think they all are available generic right now. So the generic medication is still cheaper, but usually insurance will still cover the long-acting injectable if they have insurance. Medicaid covers them all, so it's very inexpensive for them to get the injection through Medicaid in Missouri. In other states, it may be different. And then again, Medicare covers them sometimes, so we have to look at that. And then all these companies have assistance programs too to make it so that people can afford the injection. But you know, again, when in doubt, you keep someone on a generic pill until you get approval for them to go on to the injection.
Thank you.
You're welcome.
Another thing that I would say that I have relied on Matthew for quite a lot when I was working in inpatient is there's always kind of a protocol of starting long-acting injections. And so the rationale is you don't want to give a long-acting injection that lasts a month, 2 months, 3 months to someone who's allergic to it. And you want to get the levels up to maintain them through the long-acting injection. And so what Matt has helped me do is, okay, if I want to start someone on Abilify Maintaina, I'm at 300, I start them at this dose for this many weeks. Same with Invega Sustenna. Okay, what is it? Risperdal. Okay, what do I need to do? What pill for how long at what dose do I want? And so what I would recommend, what helped me was create a cheat sheet. And that's where farm reps who sometimes can really take a lot of time of your day, but they can help you. Okay, this is my medication and this is our protocol, and write it down. And so that would be my suggestion for you all when you're in clinical is, ask your preceptor and kind of get a cheat sheet going, because you'll get in that situation where you want to start a long-acting injection, but okay, what pill are they on? Do we need to titrate it, cross titrate it? What do we need to do to get this patient ready for the long-acting injection?
And to give a demonstration of that, since 2 of the injections are aripiprazole has takes about 2 weeks to know for sure that someone is not going to have a negative reaction to it, whether that be an allergic response or akathisia or EPS or what have you. But someone doesn't have to be on aripiprazole for 2 weeks for you to know that it's safe to use as far as the long-acting injectable goes, unless you want to completely avoid all side effects except perhaps an injection site reaction. So in the research study, people got oral aripiprazole for 3 days prior to getting their injection to make sure they weren't allergic to it, because that's the main consideration. You don't want to give someone an injection of something they're allergic to, because then you're going to have a crisis on your hands where they're going to the emergency room and being hospitalized until enough of the drug is out of their system that the allergic reaction can come to an end. That's just too much to deal with. So 3 days of oral medication, and then it's okay to give the injection for the most part. Again, with that in mind, if you give someone aripiprazole for 3 days, they don't show any allergic response, and then you give them the injection, and that's when they start having problems with akathisia. Now you've got to treat for akathisia until it goes away, and that takes about 2 weeks. So it varies as to, how long they have to have an oral before they get started on the antipsychotic. But like I said, when I was going through the slides, Abilify, I can't even remember where I was going with it. No, I can't remember where I was going with that statement. Sorry, getting sometimers disease. It's not Alzheimer's yet, it's just sometimers.
Yes, well, it's also a Monday. It could be
Yeah,
the Mondays. So any other questions, comments, or concerns about long-acting injections? Okay. Well, I recorded this. We're going to be putting it on our YouTube channel, so they'll be posted soon. And thank you, Matthew Lindquist, for your time and your expertise. I always love listening to you talk. So thank you, everybody, and have a good rest of the week.